they tell you about their health problems. So everybody's got problems. The question is what we do about them and who's going to do something about it. So I chose to come out of retirement, and yeah, that's how old I am, to get involved in fixing a problem. Unfortunately, COVID happened, and then I got involved in fixing COVID. So what's the problem? So the problem is we spend a lot of money on healthcare in this country. And when I say a lot, 8.5% of our GDP. And we are somewhere between 35 and 42 on the world rankings of GDP, whether it's GDP pure size or whether it's GDP per capita. That's the range. So we're a middle income country, piddly compared with the United States and Canada, and China and Brazil and the big ones. But we are still a pretty big economy, and we're still a pretty good per capita economy. So we sit in this middle where we spend 8.5% of our GDP on healthcare. Countries that are similar to us in terms of size and GDP per capita spend on average 6.5% of GDP on healthcare. And here's the rub. They get better health outcomes than we get. I worked in Ghana for 6 years. I've worked in Nigeria for 16 years. Ghana has better health outcomes than South Africa, and it's somewhere around number 79 or 80 or something, and it's a poor country. They have better health outcomes, fewer maternal mortality, definitely less infant mortality than we have. So what are we doing wrong? If we're spending all this money, what are we spending it on? Well, we have this dichotomous situation where we spend 51% of everything this country spends on healthcare in the private sector, on currently 14% of the population. The population has gone up, and the number of members and beneficiaries of medical schemes has not gone up for several years now. So we have 9 million people who spend 51% of the spending on healthcare in South Africa. And then we have the 49% of the spend, which is spent on the remainder. So at the moment, it's 86% of the population. There are overlaps. There are people who don't want to wait in queues and go and get their health care in the private sector, even though they're not members of medical schemes and they buy out of pocket. And there are people who have medical schemes, both comprehensive schemes, but more often hospital packages, who then can't afford all the health care that they have insured themselves for through a medical scheme, and they get their health care in the public sector. And then there are some services that are not available in the private sector. They're only available in the public sector. So if you have the misfortune to have 40 or 50% burns, you will not be able to get health care anywhere in the private sector. You will have to go to the public sector because we're the only ones with the big burns units in the country. Of course, the public sector is also responsible for all the public health programs. All the vaccinations, the malaria control program, the food inspection stuff, and so on, all comes out of that portion for everybody. So the actual spend is probably worse. So we're spending a lot of money, and we're not spending it smartly. So let's start with the public sector. How do we spend this 49%? It's 265 billion rand, roundabout. So there's a little bit in the correctional services, 1.2 billion for looking after inmates. There's about 4 billion, 4.5 billion in the Defence Force for the South African Military Health Services. About 200,000 people get their health care there, beneficiaries and armed forces. The rest is in the 10 health departments. So we cringe when we hear you in the media talking about the health department. There's no health department. There are 10 health departments, and that's a problem. We have a constitution that makes provinces pretty autonomous, and they get their money through provincial equitable shares, lump sum. And then the legislatures of the province allocate the money to their functions: education, health, social development services, sport, Sia Kolisi, Rachel Kolisi, Sophia Kolisi. No, but whatever, just checking you're paying attention. So we allocate, don't worry, my dear, it's fine. We both a bit deaf, I'm sure it'll be fine. So the problem is that We have 10 different health departments, and oftentimes they duplicate, they purchase the same thing by going out on their own tenders instead of using one, and they waste time and space and effort and don't buy to best advantage by using the purchasing power that government could have as a whole. And then secondly, as we know, there's fraud and corruption, mostly corruption that goes on in the public sector, and we're not proud of it. In fact, it's an extreme irritation for people like me when these things happen. The size of that corruption is very difficult to measure, but it's billions. We know that. And we work with the SIU and the fraud. You know, the president set up this fraud and anti-corruption forum for the whole health sector. And so we work with that forum in trying to understand what is causing the corruption in the public sector, where is it, and how do we either intervene before it happens by reducing the risk or act on it. The other half, in the private sector, has 71 medical schemes, 311 options. I hope you all know which option you're on and what it covers. Yeah, until you get sick, then you'll discover it didn't cover that. You might get, like my 93-year-old father-in-law got recently, a 57-page prospectus on what he's covered for and not covered for. Fortunately, he's a male, so the pregnancy pages were easy to ignore. But for the rest, you know, how does a guy of that age understand what is in there with all those big words and this plan and that plan and the next thing? But wait for it. These 71 medical schemes that we've allowed as a nation have got 833 trustees that must all be paid. They each have to have a principal officer, and there are more than 10 of them whose principal officers earn more than 5 or are paid more than 5 million rand a year. They go up to 7.8 million rand a year. That's like 4 times what the minister earns to run a medical scheme for a couple of 100,000 people. You are paying for it. So we have allowed, I'm not criticizing them, I'm just saying this is the size of the problem. Now, it's complex to know whether Antoinette qualifies for this on this day and must get a pre-authorization or not. And Mr. Beloy qualifies for that, and but does he qualify on the day? It's a bummer if you were run over in the traffic and you're unconscious. So someone has to work out whether you go in the government ambulance or the private ambulance. You arrive at the private hospital, they realize, no, sorry, your medical scheme's expired, or you're on a different plan. You can't go to this hospital because it's not part of our network. You must go to that one. Now, the systems that are required to administer all of this are complicated. And patients and doctors have learned to game them. So they reported last year in the private sector 30 billion rand fraud. So they don't have the same kind of corruption we have in the public sector, where you come and I bribe you, you bribe me, we share the difference, like that. There's a different way of sharing it. In fraud, I take your medical aid card, I pretend to be somebody else, I go to another provider, and I ask them to add a few items onto the script before I leave, because I know that my mother-in-law is not on a medical aid. There are 1,001 ways to game the system. Practitioners do it, doctors do it, other staff do it, patients do it, everybody. It's a pastime these days. Nobody stops at traffic lights, nobody stops at wherever, so why should we bother? So it's a problem. The private sector is a problem, the public sector is a problem. But we spend this huge amount of money and we don't get the kind of outcomes that we should be getting. So what the NHI says, look, it's not about a fault or blame. The Constitution makes what it is, and the Health Act as it is at the moment makes it as it is, that's how the public sector works. Procurement. If the public sector wants to purchase a service from a private provider, they must go out on tender, and they must go through all that rigmarole of mine, yours, the mafia, the what, to purchase oncology services, a hospital bed, whatever. Ask me. I was the one who did all those negotiations during COVID. I want access to a bed in case a public sector patient gets sick. Oh, well, that's going to cost you. I said, no, it's not. Here's the price, period. People didn't like it. They wrote nasty things about me in the media, but everybody fell in line eventually. And nobody lost money. They just didn't make huge profits out of it. So we have to learn to use all these resources together. 67% of all specialists in this country work in the private sector. More than 90% of all oral health practitioners work in the private sector. Who's looking after the poor public patient? It's not okay. We have a constitution and Section 27 in the Bill of Rights that says we have a right of access to health care. So we need to make sure we all get a right of access to health care. And how do we do it with these resources? So the NHI basically says, let's correct these things that have evolved over time. We're not blaming somebody, we're just saying they've evolved over time. And let's look around the world and see what others do. And there are a number of people, what I haven't mentioned is we've got the highest Gini coefficient in the world. So what that means is we have the most inequity in the world. Okay? The smallest number of people who own the largest portion of wealth and income compared with any other country in the world. And not by a margin, by a lot. Brazil trails, okay, Namibia and Botswana are quite close to us, but we are part of the same SADC community and they are small. But in terms of big countries, Brazil is the next one. And we're well ahead of them in this inequity. So we look at other countries and we say, what have countries done who got themselves into similar problems to ours? And the answer for most of them is that they have created a national health insurance of some form. Some of them have created more than one stream, parallel. Others have created a far more aggressive public health system than ours, than what we are aiming to do. And some have sort of fiddled on the edges. They're all different. And they depend on their history, their geography, their constitution. Some are federal, some are non-federal, some are small, some are big, and so on. So we've looked around and said, what is the common denominator? The common denominator is that we all signed the UN Charter on Universal Health Coverage. And please call it universal health coverage. It's not universal health care. That's something that doctors talk about, that they may have a definition for it, but there isn't an official global definition for it. Universal health coverage is a United Nations agreement that we signed. And basically, our president, this very president we've got now, Ramaphosa, signed it. It says we will strive as nations to make sure that every person gets the health care that they need, when they need, where they need it, without incurring financial hardship. Which includes me and my kids and you and your kids and the guy outside who's begging. We all incur financial hardship for different reasons. This little boy that I'm watching, who's in my grandchildren's school, who's got 40% burns and is in Baragwanath Hospital at the moment. There's no ways his folks can pay for that. He's been there for months. And he's on antibiotics that Afrikaans says krik vir niks. It's like the big guns. It's expensive stuff. So the state is picking up the tab. There's no ways that his parents can pay cash. There's no ways the medical aid's going to pay for all of this. But we will do the best for that boy. So how do we make sure that I get the healthcare that I need, when I need, where I need it? Well, what we do is we make one big massive stokvel. I mean, really, that's what it is. We pool our money. And the way you do it when it's public money is you use tax. I'm going to come back to the tax at a moment. So right now, the 265 billion that we currently spend in the public sector is your tax and my tax and everybody else's tax, including the VAT that poor people pay, the taxi levies, everything, because we don't have ring-fenced financing in this country. Okay, so we put all of this money into the Treasury. We hope that they are all on top of their game. We've had the budget recently. We know it's hard times. And we buy as much as we possibly can with that money for the public sector. We are now saying, well, we should actually have a bigger pool and we should buy for everyone. We shouldn't have 71 times whatever to 311 different options. We should all pool it. And if you really need something that's really complicated and expensive, that's fine. But most of us don't need that kind of health care. Most of us need the everyday care. And that's where we should focus on preventive, promotive, get healthy, stop diabetes before you get it, stop HIV before you get it, stop hypertension before you get it. And then we don't have to spend money on all those things. So what can we do to do that? So the NHI bill, if you read it, Section 10 deals with the functions of the fund. Section 11 gives the fund powers to employ some staff. By the way, we won the court case yesterday, so put that in your notebook. Against solidarity, we're very relieved and happy. We need to then make sure that we have the electronic systems to run the business. We need to make sure they have the people who are competent to run the business and so on, because we're going to administer a lot of money. It's going to be money coming in and going out every day. In, out, so that we're paying providers. Now here's what they don't tell you when the money webs and the big guys get going in the national media. And then I was explaining to Mr. Baloy, I saw a program by mistake the other night on ENCA, and I phoned in immediately to say, I want right of reply. Guys talking nonsense, man. You can't get away with that on national media. And then I came with the facts, and then she was trying to stop me. I said, no. Hear me out. There are 9 references to how the fund will purchase from private providers. So you can't say we've written the private sector out of the NHI. I gave every clause where it says very specifically what's going to happen. So the fund will receive money and will purchase the service. So if you're on a medical aid, that's what they do. They receive money and they purchase a service from Mediclinic and this GP and from Netcare and that physiotherapist and whatever. The fund will purchase. But the fund will purchase in a particular way that is efficient. So that's what we've learned from our going around the world and looking at Thailand and Indonesia and other countries, is you have to use what's called strategic purchasing. It's not a foreign concept. It's well known all over the place. Basically, we watch where's the gap in the healthcare. And if we're spending 1/10 in this community of Amatola compared with that community in Buffalo City, the question is why? Can't we move some of the providers from here to there by giving them incentives to move? Or do we bash the patients in so that they can use the providers in another area? How do you go about strategically purchasing and saying, I've got this money. I want to get more for the rand that I'm spending. Well, there are ways to do it. Don't have 71 medical schemes. Have fewer. Don't have 311 options. Don't have 9 provinces all doing different things. Simplify the way that you put your administration together. You can still have administration, but do you need all these layers of management of all these different things? So the NHI bill says that we will create one fund who will purchase healthcare for all of us, and they will purchase the benefits that the fund is able to pay for. So if the economy is pumping, you have more benefits in your package. If the economy is struggling, you may have to have fewer benefits in your package. That's how it works. Ghana's package, if you go and look up the Ghana National Health Insurance Scheme, has got a very thin package. But it's so well targeted that that's why they're getting the impact that they're getting. They have their problems and they have their corruption as well. And we've learned from what they've done not to do things the same way. But it still gets better outcomes. And that's what we want. We don't want mothers dying in pregnancy. But we get mothers dying in pregnancy unnecessarily. Why? It's too far. There's no obstetrician. There's no GP that's qualified. There isn't a theatre open. There isn't a this. There isn't a that. But they had to drive from Diepsloot past 4, if not 5, private hospitals to get to Charlotte Msege Hospital, or 3 to get to Skinny Jeans Hospital. You all know it's Skinny Jeans Hospital, Tembisa. So, sorry, it's just I give these things nicknames because otherwise I'm just checking if you're awake. Okay, so what I like to tell people is to get from Diepsloot community to Life Always Hospital, which is the nearest hospital, is 14 minutes by car and 11 minutes by taxi. Give yourselves a hand. Well done. Okay, so the point is, The point is, if we start to use all our resources smartly, we can get people greater access to healthcare. Why does the guy, I live in a leafy suburb of Pretoria. It's not so grand, but it's quite close to the grand place where all the embassies and all of that is. So we have a lot of staff of embassies and so on. So it's pretty much private healthcare, all that suburb. But we all have security guards and cleaners and gardeners and people, many of whom who live in our suburb in back rooms and whatever. Now that guy who works at security at my complex must go to Mamelodi or Atteridgeville to go and get his health care. But I've got 5 private hospitals within 5 kilometers of my house. The first public hospital is the Tshwane Academic Hospital, and then next door to it, Steve Biko. And that's Durangon from me. It's double the distance to the 5 private hospitals where I live. Now, why must the poor guy go to far away and I can go nearby? Why can't we just buy healthcare the nearest place? Why can't he go to the GP that I go to, who's less than half a kilometer from my house? Why not? The matter is he can't pay, and I can pay. But if somebody's paying for both of us, he can nip out, get his antihypertensives or whatever he might need, and he can be back at work in no time whatsoever. In fact, he might even be able to collect it on chronic medicine, the CCMDD program of ours, when he goes down to the spa to get himself something to eat. The point is, we are not using our resources smartly. We're using them in a very expensive way that does not necessarily get an outcome. It does not add value to have a menu at your bed in hospital or a TV in your room. It might be nice, and maybe you can buy that extra. But what adds value is good nursing care, good medical care, clean wards, access to theaters, the right medicines. That's what makes the difference. So that's what we are trying to do. So the NHI bill says the fund will buy from public and private providers. How we will buy, there are 4 different ways that are spelled out, and they're broad global economic things. One is capitation, which is how we'll pay for primary health care. It's complicated to talk about here tonight, but I'm happy to talk about it another time. The second way is what we call global funding, where you have what are called diagnosis-related groups. Australia was a sort of pioneer of it, but Russia has got a couple of very good mechanisms. The US has got a couple, and there are other countries. They've copied sort of from one another as they went, and they've improved on them as they went. So we've got lots of examples of DRGs. Then it says we will pay capped case-based for ambulances. That's a unique thing we have to do because the Constitution makes ambulance services not a concurrent function. I don't know why they did that, but it says ambulance services are a purely provincial function. Anyway, and then there is a global lump sum budget which we would need to use in transition. If your practice is not ready yet, we have to pay you a lump sum. If your hospital is in the public sector, we might have to pay that. So there are different mechanisms available, and that's what we are doing in the department now. We're taking previous work and research, and we're saying, okay, now how do we do this in practice? The trick is to make sure that we have one common digital system. So what we are busy with at the moment is the electronic, they call it patient record or medical record, where we will go and if you got COVID vaccination, I'm not going to ask you to raise your hands because we don't want to fight, but if you got COVID vaccination, you're already registered on the system. So once or for the rest of your life, we know about you. Then you, well, if Home Affairs knows about you, we know about you, because that's how government works, I'm afraid so. We don't know a lot about you, but we know about you. So you have registered on the HPRS, the Health Patient Registration System. Then you need to go and enroll at a GP or a clinic or a place where you will choose to get your routine primary health care. Once you've done that, that person will be the one that we will pay to look after you. And if that person cannot look after you, and we are trying to encourage people to work in what we call multidisciplinary teams, then what you will do is they must refer you to somebody who can look after you. That's what it says. So if your kid's broken an arm, you're not going to look after you in the rooms. They didn't take an x-ray. They'll send you somewhere for an x-ray. They'll put the plaster of Paris on. You'll come. They'll give you ongoing treatment. They'll look after you until the end. So that's how you all work. So you have choice of that provider. And when you need to be referred, you have choice. So I've got 5 hospitals near me. I chose that I like to go to that hospital. I say, sorry, they don't have, for argument's sake, neuro or psychology or whatever's driven me crazy at work. No, I didn't say that. If they don't have that service, then the GP must find another hospital that's got that service or a bed available or whatever. But it must be my security guard and me. We must be dealt with in the same way. So that's the direction that we're going in. So I want to just deal with one last topic, and that is, how do we pay for all of this? And the answer is, we have 277 billion in the private sector at the moment, and we have 265 billion in the public sector at the moment.
Private sector, how much?
277.
277.
And 265 in the public sector. That was 2022-23 figures from Treasury. So, I mean, it could be slightly more because it's hard to measure out-of-pocket spending. That's done on surveys rather than on actually counting cash. Whereas in the public sector, you count cash. This is what you spend. And that includes capital spending, routine spending, maintenance spending. It's everything. That's what we spend on the health sector in a year. That's a lot of money. So what the fund will be, what we would want to bring into the fund is not all of that money, because what we call non-personal services will not be run by the fund. They will still be run by the provincial administrations, the local governments, and so on. Environmental health, the aflatoxin in the peanut butter, and the other things that I'm sure you're all well educated about now. Water testing for cholera and typhoid and so forth. That all stays in the departments. What we are interested in is the treatment of the individual to be paid for, so that when that person gets sick, they don't have to worry. So the problem is this money is all in parcels, little parcels. So it could be in the provincial equitable share of the Eastern Cape, of the Northern Cape, of the Gauteng province or whatever. It could also be in a conditional grant. So those are monies that are allocated from Treasury to the National Department of Health to be a post office and to give to the provinces for additional things on top of the provincial equitable share for specific services. Tertiary health services, a thing called the Health Professions Teaching and Development Grant, which is where we pay for the training of the specialists, doctors, and so forth. So we get monies that are earmarked, they are ring-fenced, there are conditions on them. And then there are other public sector spending environments. As I said, correctional services is one. They actually buy the services for inmates. Their own staff, of course, are on medical schemes and get it in the private sector, if they can. Otherwise, if they are too junior and cleaners and things, they'll go to the public sector. But then there's the Road Accident Fund, which has also become a cash cow, as we know, for fraud, and the Compensation Commission, where we also understand that there's a significant amount of fraud that is going on. Those funds pay for things other than healthcare, but they pay for healthcare. But they pay at the highest private rates. Why? You can get that good healthcare somewhere else. You don't have to pay. Why don't they negotiate the rates? Or even send the patients to the public sector where we can pay at our rates. We are also able to buy what we call health products, medicines and devices and so on, your spare hip and your spare knee and your blood-giving set and your catheter and your colostomy bag and all that. If we buy all of those things for the whole country, we give certainty to the pharma market, we give certainty on the time frames, we can give it for 2, 3, sometimes 4 years, if we are lucky with Treasury's condonation. And so we give massive certainty, and therefore you can negotiate good prices. Actually, we'd like to buy for the whole of SADC in the same way, and then you really get good prices. But right now, the private people have to buy 1, 1, 1, 1, 1, 1. So they are reliant on much higher prices than we are able to get through tenders in the public sector. So the fund will run that. So you can reduce the administration in the private sector by 16 billion just by not having 71 medical schemes. That's what it costs per annum. 16 billion. Just administering the money, not administering the practices. Then you can reduce the public sector costs by getting rid of 9 different departments all duplicating one another's activity. You can get rid of some of the over-servicing in the private sector, which we know is there, the health market inquiry. You can go and read all the examples of what happens. You can get rid of the complexity, the fraud and abuse in the complexity of the many switchings of monies that inconvenience us when we want a pre-auth. You don't need a pre-auth, you just go. Your doctor sends you and that's it, it's going to be paid. And we can negotiate the prices down because we're buying a lot and getting volume. I don't want to oversimplify it, but it works like that within a big medical scheme compared with a small medical scheme, and it works like that from a big government department compared with a small one. So the bottom line is we have a lot of money, but it needs to be shifted. It's not new money. So the public money is relatively straightforward to shift. It still needs laws to be changed, rules to be made, got to be done gently and slowly so you don't break the system. The private sector money is more difficult because you can't just move it. However, there are parts you can just move. I get a tax credit every month of 326 Rand or something. So does the president. So does Neil Froneman. You all know who's Neil Froneman because you are in the media. I mean, this guy earns, what did he get that other time? 300 million Rand a year? So we as the government give him 326 Rand a month. Why? To encourage him to use a medical scheme. Now I ask you, for those of us who earn a lot, and you can choose the cutoff, just cancel the tax credit and put it into the public health system. What's the problem? I'm not asking that we take it from someone who earns 12,000 Rand a month. So that is a low-hanging fruit. There are other low-hanging fruit within the private space. I pay, okay, I'm a different kind of public servant because I don't qualify for all these things because I joined too late. I was what do they call it? Not one foot in the grave, but killing on the back. So I was old, so I didn't qualify for all that stuff. So I don't have those medical schemes and things. But a lot of people do. And 75% of that is subsidized by the state, by you and me and them as taxpayers, to pay who? The medical schemes, who take off 16 billion Rand a year to administer, including Polmed, JMs, whatever, administering the very own same public servants. So why don't Labour say, no, I don't want to put my money there where it's spent on this inefficient system. Let's just put it in the fund. Take the 70 billion subsidy that the state gives and put it. So I'm giving you an example. These are not small sums. The tax credits are 37 billion Rand a year. The government subsidy to medical schemes is 70 billion Rand a year. And that's just public sector PSA, Public Service Act public servants. That's not all the entities and all the others. So there's a lot of money already in subsidies that could be moved. And then there's me and people like me who's on a hospital plan and hoping like hell I never get old. But now the visits to the GP, you and I both, we'll chat afterwards how you're doing it, because I want some lessons, please. So now we start to realize I never used to see a GP. When I get sick, I'm man down. I'm like, you have to resuscitate me. Otherwise, there's no, I think, something in between. But now you start getting older. Now you need GPs and you need chronics and you need, not me, I don't need chronics yet. But you get the point. But now I've chosen a hospital plan, or I'm 25 and I've just finished varsity, I've just got married, and now my husband helps me to get pregnant. Now what? I will put myself on a hospital plan because I can't afford something else. But now who's going to pay for my antenatal and my this and my that? Because this is all out of pocket now. Those people can't wait for change. And there's lots. 25% of all members of medical schemes and beneficiaries are on hospital plans. Only 35% are sitting in comprehensive plans. So, I end what I've said. I know I've gone on and I rambled. You allowed me to, thank you. And you laughed at my jokes. But this is a serious matter. We have enough money in this country. It's going to be painful for those of us who have privilege to share that privilege, to share the dentist, to share the whatever. But it's good for the country, because it means we will have fit and healthy workers. We'll have people who are not on their knees, suffering, unable to get jobs because they're unhealthy. And it's good for all of us. We saw during COVID. The guy next to me gets COVID. Am I going to get COVID? Sure, I'm going to get COVID, unless I stand 2 meters on the strip and whatever. So I invite you to write factual reports. Please go to our webpage of the department. If you don't know anything, Dr. Chwala Saje, where are you? There he is. He's in the minister's office. I've got another colleague with him and me. Foster is not yet. He's on another event tonight. Foster Mahali, I'm sure you know him. We've got our colleagues in GCIS. Ask, and we will provide you with the necessary information. Thank you for your time and listening. Thanks, Antoinette. I'll stick around for a few questions.
Doctor, I'm going to take 3 questions because the whole idea is that we need work. So you are welcome to come and chat with Nicholas afterwards. There are a few arranged interviews.
Sorry.
I know Rihanna has one. So
Can I finish my wine?
you also want one. We just have to accommodate that. But apart from that, the most important is that you can get your drinks at the bar and there will be food. So, first question. Peter?
Yeah, if
Just introduce yourself.
Sorry, I'm Peter and I'm from Namibia and it's a good thing. I'm going to be a bit biased because I'm totally for something for everybody, like you said, the gardener and everybody else that can just use the doctor that's like 5 kilometers away. But we do have a problem, and we see that, especially with us reporting about health and health issues, is that the hospitals or the provincial hospitals are not looked after. They are not managed correctly, and I think that's a problem because we've got capable doctors in the public sector or in the government sector. We've got more than able doctors that are willing to help. But I mean, I've seen it countless times where doctors and nurses go and there's not even running water for them at the hospital. Now, again, in News 24, they said that in the Northern Cape, one of the hospital's telephone systems was cut because they didn't pay. And then there's, the cardio, for children that's got, heart conditions. There is a cardio of 25 million, but it's not working. And that's like disgruntling the people, the nurses, and the doctors that already work there, that really wants to make a change and makes a difference. So how is that going to be managed? Because I think if you can get that right, this is going to be a win for everybody.
Okay, you want me to take them one at a time?
Let's take them one by one.
Okay, I'll try and keep it short, one by one. So the reason, if you're spending 27,000 rand per person per annum in the private sector and 5,000 rand per annum in the public sector, you are going to run the public sector down. 5,000 rand per person. You can't run the same service for 1/5, and that's the problem. But even the little bit that is allocated on infrastructure management is managed by another department. And that department's got pressures to maintain the building, the Telkom building where it's 40 degrees, and to manage this and to manage that and to manage other things. So I don't work in the Department of Public Works or in what they call here in Gauteng, DID, Department of Infrastructure Development, but I can say that in the days when I still ran, I was a hospital superintendent back in 1989, and we ran our own budget. I personally used to see to it that the water purification, because we were a little rural mission hospital, so the water pump and the big water tank and the sewage system with we still had those aeration ponds and things, I don't know if you still have them, whatever. All of that we ran ourselves. We had our own budget. We maintained our own broken windows, our own doors, our own everything. That's what we want from health. We want to give the manager of the hospital, you can't have Helen Joseph, where the toilet is blocked and they must write a requisition to DID. And there are 23 ambachtsmense on the premises, but they haven't got the goods to open the toilet. You can't work like that. Back in my day, we had 3 factotums in a 450-bed hospital in Zanin, outside Zanin, Lataba Hospital. It was not pretty like it is now. And we literally maintained that place as the management. So there are things we would like to change. But if you can decant patients out of public sector hospitals that are chock-a-block by taking the deep slaughter population and saying to them, there are 100 beds available for that population at Life Always, which is more or less what they tell us is available. And even if there aren't, Life comes to us and said, we'd be prepared to build on an extra 50 beds if we need an extra 50 beds, because it's in their interest. Right now they have underutilized beds. There's a hospital, private hospital that I'm told in the Eastern Cape has a bed occupancy of 30%. Can you imagine what the cost they are carrying? And meantime, there's chock-a-block in Cecilia Makawani and Freya Hospital. I mean, it's crazy. Crazy. So if we are able to decant, so what we've been doing in the public sector is taking patients who go and clog up the pharmacy outpatients and saying to them, you can go and collect your medicines through the CCMDD program. You've all heard of Double Up Meds. You can go and collect your medicine at one of these pickup points nearer to your place. And we decant them out of the outpatients and out of the clinics. So what's the response? The treasuries, and there are 10 of them, like there are 10 health departments, reduce the health budget because you're doing so well cutting the costs. Really? You know, you will never get on top of things if you don't invest in your own services. So it's not one simple answer. And I'm on record repeatedly saying you can't fix the public sector alone and the private sector alone. We all work together. I was out of government from 1999 until I came back 2.5 years ago. I worked as a private, ran my own business and worked all over Africa and so on. You can't say I don't add value just because I'm in the private, or I added more value. I was just in a different role. We have to recognize one another's different roles and use it. So I think there are a lot of us. There are not enough of us. I mean, we are up to 0.8 doctors per 1,000 population now. But in 1994, we were 0.6. I was the only full-time doctor in a 200-bed hospital for my last year in clinical practice before I finally got my specialization and left and joined public health cadres. It's hell working like that. So you don't want that situation where you are too few. Nobody wants that. But you also don't want everyone pushing off at 10 o'clock and doing things that are unnecessary and overservices. I think we just have to samstand. That's what South Africans have done in the past. It's what we have to do again.
Frans, you had a question?
Thank you so much. I want to say Nicholas, but somehow I'm tempted to continue saying Doctor. I'm going to wear my journalistic hat and take off that of the National Press Club Secretariat. And I'm going to put you on the corner that is not yours. And that is mainly for the politicians and the spokespeople. Maybe you'll then invite William or any other person to come in. But the High Court in Gauteng has dismissed, I think it was yesterday, has dismissed the Solidarity's attempt to stop the implementation of the NHI or so on. Are you able to tell us what was the concerns or what were the concerns of the Solidarity? And at the moment, what is your feeling as the department on this court ruling? Thank you.
Okay, so let me keep it short. We advertised, I was employed. The advert was put out, I was interviewed along with other candidates, and I was employed to come and help design the National Health Insurance implementation. Not to implement it, because there's no bill yet, there's no act yet, but to design the implementation. And I then made a motivation through the DG and through the Minister and the Minister of Public Service that I need people. I need accountants, I need an actuary, I need some digital people to work on the IT systems, I needed people. And in discussions with Treasury, they had already set aside a sum of money, but it was for getting consultants. And I said, no, we're beyond getting consultants now. If I get consultants and I appoint them for 1 year, I pay them double what I pay an employee, and I've got no retention of skills, whatever. Can't we please just employ the people using that money? And DPSA and the department agreed that we could employ 44 people. 44 people. Now let's put it in context. There's a medical scheme administrator in Centurion that just in head office has, according to their website, 2,700 people. There's a big one in Sandton that apparently employs 10,000 people. There's a government one here in Pretoria that apparently, with the contractors, employs 4,000 people. You see where I'm going? I wanted 44 people to help me, and Solidarity objected and said, I'm wasting the taxpayers' money. I'm not implementing the NHI. So their case said, we can't implement the NHI because there's no act. Do I look like I don't know that after 40 years of doing what I do? So our argument was, we are not implementing anything. We are planning. We are preparing. Government has a new policy. You can't expect a government to want to have a new policy and then you wait until the legislation to plan what you're going to do with it. Imagine what you guys would have written in the media if we didn't think ahead. So we were thinking ahead. And the court said, you have a right to think ahead and employ the people. So we are happy. I've got some people. Thank you.
The last question. Guys, do you mind if I give our honorary member Roy the chance? You other
Yes, the working journalist there.
Nicholas will still be there, we can still chat to him.
Just the last one from the working journalist. I'm so sorry, Chair. He's working.
You're being unruly.
Who's chairing now? You can't chair from there.
Okay, Roy and Olivia, and that's it.
Doctor, thank you. If I may be rather cynical, a brief background. I worked at various newspapers, including the Randall Mail, and we did a thing there about government misspending, which actually pales today when you see how much money is being misspent. That's what I would like to know, on an almost cynical basis. How are you going to be able to stop the corruption and the fraud and the slinking genius? And the other point is this, is I totally agree with you about this idea of too many departments. I think it's a political move, and there's a hell of a lot of people earning a hell of a lot of money and doing a hell of a lot of little. Thank you.
Okay, so I should have touched on, Roy, thanks for the fraud and corruption bothers me a lot. Those who have known me for a long time, and there may be a few in the room, Boris just left, but he's known me for 35 years. I will tell you that when I was HOD in Limpopo, if you tried to do something, you were chucked out on your ear. So I have never tolerated that, so I really, it's an issue for me personally. Okay, so what do we do about it? So remember that the fund is going to be the purchaser. We're already a purchaser-provider split. The providers must still deliver their care, their services. So the provincial department of whatever province, I don't want to pick on one, must still employ staff and deliver services, buy medicines, admit patients, clean their buildings, build their buildings. That's not the fund. That's not the NHI. That's the provider's program. But they will now have to compete with the other guys who allegedly send the patients into ICU before they die or before they're discharged so that they can get a higher payment. I've got to stop both of them somehow from wasting money or crooking the system. And as I said, there are lots of examples all over. So there are several ways that you can do. You won't stop it all, but you can certainly make it hell of a difficult. The first thing that you do is you have to reduce the risk. And to reduce the risk or eliminate the risk, you need to identify it. We know that duplication is one of the biggest risks. And having the guy who controls the pot and controlling the services and the employment of the staff being the same person, that's bad. If you split that and you don't have the same person paying, actually employing the person, then there's a greater element of honesty. We also know if we reduce all these switches, that people don't have to go and play this dance to try and game the system. You reduce a lot of risk. If I don't need pre-authorization, I can reduce a lot of risk because people play with it. I recently had to have a special investigation done. It was an MRI scan. And when I arrived at the place to have it done, now I don't have a real medical aid. I've just got one of those mañana ones, you know. So I pay cash for everything until I'm admitted. So they said, no, if we admit you, your medical aid will pay the 10,500 rand. I said, but I'm working. I'm busy. I can't be admitted in hospital. And besides, that's dishonest. I'm just having an investigation. So I had the investigation. I went to pay with my credit card. I said, do I get a cash discount? The lady at the reception says to me, yeah, 7,500. She just told me 10,500. So the medical scheme would have paid the 10,500 and the hospital admission. Can you see the chukare? Some of it is designed. So I can give you plenty of examples, and it's a systemic design and manipulation problem. So the bottom line is, you first of all design out all the risk you can. Then, because you've got all your processes mapped out, you know I can't design this out, but there's opportunity for fraud. So you flag it. So when a patient comes and claims a second appendectomy, or the male comes claims a cesarean section, and you check and the patient is not transgender, this is a pure male, then you flag it, and you know here's a problem. So the medical schemes do it. We don't do it in the public sector because there's so little money going anyway, and there's other things going on. But in the NHI systems that we're busy designing, that's exactly what we are doing. And then you have to catch them and clap them. And that's the trick. The trick is to catch people. So inside the design of the NHI fund, much to the chagrin of some people who are criticizers, how are you going to examine yourself? Well, every private company that's worth its salt has got a risk program and deals with its internal stuff. Then when you catch them, now you refer them to the authorities who have the powers to arrest and investigate. And if it's the SIU, or if it's the Hawks, or if it's the police, or if it's whatever, we'll do that. But then we have to fire them. So in the case of providers, when it's not our staff, just terminate their accreditation and they can't be paid for the services they deliver. So you force people to be honest by design. Anyway, I could go on all night about the details of what we know and what we don't know.
Thank you.
William.
From News 24. I've been in Canada for about 2 minutes. I don't know if I belong here yet, but
You do.
So right at the start of your talk, you spoke about how, in a way, there's no solution. Every system has its flaws. I wonder what you would identify as the flaws, the legitimate criticisms of a NHI system. Given the media criticisms, what downsides do you view as legitimate?
Okay, thanks. So the biggest downside is it takes away people's profit. But that's not my worry, because I'm a doctor. So I'm not, and I've been a mission doctor and a public health person my whole life. So quite frankly, it's not a worry for me. But there are worries on the way. And that is that people's perception of what they are being reimbursed for doing a good day's work, and if it's not enough, they threaten to leave the country. So we're busy with a big survey. We're about to launch a very, very big survey of all health professionals in the whole country at the moment. to understand what do people understand, what do they know, have they just listened to News 24 or did they listen to us with respect? Because I think that some of your reporters really have got it wrong, I'm afraid. So I hope you're going to be a lot better than some of what we reach. Thank you. I will tell you the names of the guys who got it badly wrong. Not here, but privately. What's your name? William? Yeah, that guy. So it is a downside that if you are unable to pay people enough money. So what did Bevan say in 1948 when they launched the NHS in the UK? The doctors wouldn't come on board and wouldn't come. By the way, every country has the doctors who don't want to come on board, and when they're on board, they're actually happy. And when they wouldn't come on board, he said, I smeared their mouths with money. That's how I got them. So he paid them more. But ours is quite hard because the differential. So I don't know if you know what public sector doctors earn, or what we pay them. I'm not sure they all earn. So somebody in my position who works as a clinician, as the most senior, like I'm almost on my way out, costs the public service, you and me as taxpayers, 3 million rand a year. So that's what the heads of clinical departments, that's what they are paid with their salary, their allowances, their overtime, and whatever else are due to them. It costs the public sector 3 million rand. We expect a lot out of somebody who earns 3 million. Junior doctors, my junior students, less than 5 years will earn more than I earn. Because we pay clinicians better than we pay managers in the public service. And besides, I was retired, so I had made my own plans already. So we can't get the really good people to come into the management position. You really have to be crazy. When I was a young doctor, we said there are 3 M's of why you work in a mission hospital. Mad, mercenary, and missionary. So mad is self-explanatory. Mercenary is in a space of 1 week. I probably did more cesarean sections than most gynecologists do in a month. Missionary. Well, it doesn't necessarily mean you've got spiritual zeal and you work for your radio station. It means that you just have this desire to do things right. And many of us had all 3. So that's the downside, is not everybody is mad, mercenary, or missionary. And those who are mercenary are very mercenary. They are a handful, but unfortunately it's enough, who will psych everybody up that you're all going to earn nothing and it's not going to be worth it and you can't. We haven't had that discussion yet. How do people know? How do they know what they're going to get paid or how they're going to get paid? I can tell you now the GPs will be better off than they have been. Because the way that our private sector is structured is very specialist dependent. People take their kids with scabies to a dermatologist or a pediatrician. My mother-in-law could have looked after those. Okay, she was a nurse. So take somebody else's mother-in-law who wasn't a nurse. Could also have looked after that child. But the worried well mothers will go and take a slot and pay their whatever, 1,000 rand, 2,000 rand, for the dermatological conversations for the little ho-ho. Those are the wastes. So people will have to, providers of healthcare, will have to reorganize their businesses. There's a downside for funders, because we don't need 71 funders, and we don't need 311 options. Whether we need 10 or 15 or 20 when we're done, who are looking after what we call the complementary health services, the big fight around Section 33, I don't know. It'll work out when we get closer. You can't design everything now. But we don't need that level of complexity. So the change management is a big part of getting where we're going. The disinformation. But is there a downside of a national health insurance? Sure there is. You've got a large sum of money in one place. It's got an upside to it. For every pro, there's a con, and for every con, there's a pro, I suppose. You have a risk by putting all your money in one pot. But there are ways. Big fund managers will tell you they split it. They put it in different bank accounts, so you can't get it all at once. They change the way that they draw down on their bank accounts. They change their investment strategies. They do all kinds of things. I'm not a finance person. But you don't have to put it all in one big bank account. You can still manage it differently. But yeah, that's a potential problem. But Indonesia's got 250 million people on their NHI. And it took them 12 years to get there from zip. There's 70,000 islands in Indonesia. Ours should be a walk in the park. So what do we need? We need to put our shoulders to the wheel and say, hey, you're a really good actuary, I need you. You're a really great economist, come and work with me. That's what we have to do. So I'm sure there are downsides, but there are bigger downsides to the other models. What we are trying to achieve is equity in access and social solidarity, because we come from a very horrible past. Thank you.
Thank you very much, Nicholas, and good luck. I think you're going to need it. Before we proceed, just two people I want to welcome specifically. Is it Philip George? George Philip. Sorry, the other way around. George. He's a new member, freelance journalist. Welcome. I'm so glad you're here. And Michael, the press attaché from the Russian embassy. Also your first time here. Welcome.